next speaker, Dr. Ramamurthy, who's going to give us some nice sound pearls for IOL exchange. So on to you.
Thank you. I'll be talking about intraocular lens exchange. It's primarily a single video that I'm going to be showing. This was a patient who received a bilateral implantation of a spherical aberration-based lens, which gives multifocality, has worked reasonably well in many of my patients. But this particular patient was extremely unhappy, both with the quantity and quality of vision. As you can see here, he has a very mixed astigmatism, has only 6/12 vision uncorrected in the right eye, needs this kind of a refractive error. Again, he needs additional power also for near vision. And he was just 42 years old. Essentially, he had a fairly early cataract and was very unhappy with both the quality and quantity of vision. Waited for almost 3 to 4 months. He did not settle down and he was quite insistent on getting something done and also wanted the multifocality to be reduced. Since this lens was completely based upon a different principle, I decided to go ahead and replace it with a continuous range of vision intraocular lens. And as you can see over here, this is the patient about 4 months later. It's a hydrophilic lens with a hydrophobic coating. And the idea is to get this lens out. It comes with 4 closed haptics, and because of which I have to make I make a 2.8 millimeter incision, and that's essentially high molecular weight viscoelastic going in to bloat up the capsule, the anterior chamber, and giving me adequate space. And that's iris spatula being introduced so as to separate the capsular rhexis margin from the optics of the lens. Mind you, this is just about 4 months old, and it's a hydrophilic lens supposed to be with a hydrophobic coating, but relatively easy to separate it out. And now what a fairly bulky lens, what I'm doing is to bring this lens out of the capsular bag into the anterior chamber. And this was been, that's one side out, and this is the second side that's coming out. And as you can see, the lens is fairly large. And normally I would just make a quadrant cut and then subsequently roll the lens out. But in this case, what I'm going to do is to introduce the secondary lens that I was planning to implant, which is a continuous range of vision intraocular lens, a hydrophobic acrylic lens. And that goes into the bag. It's essentially IOL scaffold I'm using because I'm wary of the fact that it's a highly demanding patient. I do not want any damage to the posterior capsule. So once I have the secondary lens in place in the bag, that gives me the comfort that there is very little chance of damaging the posterior capsule. Of course, placing the lens in the bag poses some challenge because there is some amount of fusion of the capsular bag, but I am able to position it quite properly. And as you can see over here, the secondary lens that's in place, and that's offering adequate protection. Now, of course, we have to be cognizant of the fact that endothelium also needs to be protected. So again, refill with viscoelastic, going through the side port with a lens holding forceps, and I'm getting a firm grip onto the lens. And since, as I mentioned, this is a 4-haptic lens, fairly bulky lens, I decided to go ahead and bisect the lens quite completely. But a C-loop lens, then maybe just 1/4 cut and then rolling the lens would have been quite adequate. I'm completely dividing the lens into two quadrants, hemi segments. Then subsequently, I fill in with the viscoelastic and then get with the same lens holding forceps or any forceps that you choose to get the haptic, catch hold of the haptic. Sometimes these haptics tend to give way when you try this hand over hand maneuver. But then, as you can see this happening here, but a little bit of the lens is still available for me to get a grip onto this. And then through the 2.8 millimeter incision, I'm able to bring out one half of the lens out. And then I go ahead and address the other segment. Basically, the point I wanted to make here, when you're doing this, your primary aim is to protect the posterior capsule as well as cause as little damage as possible to the corneal endothelium. So placing an IOL scaffold, I think, works very well once you brought out the intraocular lens, the primary intraocular which has to come out into the anterior chamber. And then adequate amounts of viscoelastic, dispersive viscoelastic for the endothelium. And when you want a deep chamber, like when you want to bring the lens out, using a cohesive viscoelastic is a good idea. And again, that's whatever viscoelastic was introduced being aspirated. And you can see that this lens is fairly well centered. That's almost the end of the surgery. Actually, I did the same procedure for both eyes of the patient 1 week apart. And this patient actually traveled from Africa, Indian settled in Africa, who came for his surgery. 3 months later, came back, and then we did this exchange bilaterally. And as you can see over here, subsequent to the second surgery, this was the visual outcome. Very small cylinder in the right eye, but otherwise very satisfying visual outcome for distance near and intermediate. So even though the first lens was also a multifocal lens based on a different principle, that optics did not work for this patient, but then replacing it with the second lens did play a part. So the pearls for IOL exchange is identify the cause for patient dissatisfaction. If it is a PCO, if it is a bad ocular surface or some macular problem, obviously that needs to be addressed. Do not be in a hurry to replace the lens. Allow adequate time for neuroadaptation. And just in case it's a small residual error and laser version correction is possible, obviously that's a easier way of dealing with the problem. And consider the primary intraocular lens that has been implanted, the duration for which it has been in place, and account for the capsular addition that might have developed. Use both the preoperative biometry before the first lens implanted and the biometry in pseudophakic mode. And as I mentioned, measures to protect the endothelium posterior capsule. And always, this is already a dissatisfied patient with high hopes. Give a very guarded prognosis and then deal with the patient. Quite often, you might come out quite successful. Thank you so much for your kind attention.
That was a wonderful presentation and the great tips to have how to manage this difficult moment. Just one question with you before we go on to the other panelists. For a plate haptic versus a loop haptic, in what way would your dissection differ, dissecting the IOL out?
Actually, if it is a plate haptic like the Zeiss plate haptic lenses, which is also a hydrophilic lens, I would not even section the lens. What I've had two lenses I've explanted. Just catch hold of the haptic and then one of the plates and then pull the lens out. Even through a 2.8 millimeter, the entire lens folds on itself and comes out. But as you saw, this was not really a plate haptic lens. It has a four closed haptics, and I've never explanted this lens before. So I thought it would be quite traumatic to pull this entire lens out, even if I have to roll it out after a single cut. So basically, I decided to bisect the lens, and then it worked well. But even then, I took all the precautions to protect the endothelium.
Yeah. So, which lens was this? This was Proxa or just
No,
Minivel?
leave that.
Leave that part. No, we don't discuss
No,
that.
it's a spherical
No,
aberration.
I also had same problem with one of the patients. This is a problem which I also had. I also had to expand the same lens.
No, I had.
Patient was having a lot of photic glare. He was totally unhappy.
Correct. You're in the sense that, we are very enthusiastic about these lenses. We thought, this is a lens which seems to give reasonably good vision, no diffractive rings, no splitting of light. So maybe dysphotopsia will not be a problem. But though the initial experience was good, but as we placed a few more lenses, we have actually had 3 patients who have been quite unhappy with the outcome. I think the interplay of positive and negative spherical aberration doesn't always work well with all patients. So there are very stringent criteria we follow, and of course, now we are quite wary of these lenses and use them in small numbers.
Yes,
the only saving grace was that it's a hydrophilic lens, which is, even you can expand after 2, 3, 4 months easily. Had it been hydrophobic, it's really becomes very difficult sometimes, no?
Use the capsule. Tamil, can we move on to the next question?
Yes, to Dr. Titial, sir. Like if the optic haptic adhesion is very dense, if you're not able to lyse it, and what would be do you advise to cut the optic haptic junction, or how do you proceed, sir?
I think the first attempt should be to gently dissect out with the help of viscoelastic possible. Sometimes, if you go clockwise, anti-clockwise movement, sometimes these haptic may slip out. If that doesn't come out, then no harm leaving the haptic behind also. Simply cut like we had this, closed loop haptic. We can just cut it and leave it there also. It won't cause any problems rather than trying to damage the capsular bag, which is very important as such. But I've seen most of the time, if you give little more time, gentle dissection with the help of viscoelastic, ballooning out the peripheral area, then dissect with the dissector, most of the time it might come out. But if it doesn't come out, no harm leaving the haptic behind. I've left many haptic like this also.
Dr. Shrish, where would you start your dissection when you have to remove the lens and the rest? It is not going to just come out of the bag easily. Would you do it under the optic or would you start at the optic haptic junction?
Yeah, it again depends on the type of lens, the material. So hydrophilic lens, it slips out easily. Hydrophobic only is the problem. And this is actually a rare indication of IOL scaffold. So it was nicely demonstrated, and because we use this IOL scaffold for various other reasons, like managing a PCR and managing a nucleus in a PCR or a hypermature cataract when there is no cortical support. Disengaging these optics and haptics may be difficult in hydrophobic acrylic lenses. You have to inject first, you separate the capsular adhesion at the capsular margin, that is the CC margin, using iris spatula. Inject visco through wherever there is some ledge, you can just inject visco and try to separate it mechanically, and even go behind the lens and try to separate it either by injecting visco or with the iris depositor. So most of the cases you can disengage them, but as Dr. Titial mentioned, if at all the haptics are adherent to the equator, then you can leave it. You can just cut at the optic haptic junction and replace it with the new lens.
Yes, Dr. Kiranjit?
Yeah, in some cases, in spite of very good, you try to do a very good dissection of the IOL and haptics from the capsular bag, and but you don't succeed, and ultimately you end up bringing out the capsular bag out of the eye along with the lens. So you have to be ready with a standby lens. That is very important
Yeah.
because it is not 100% surety that you'll be able to exchange the lens.
Has anybody tried feeling the need to do a removal of an IOL in an open capsule? Any tip to give for that?
Oh, I think Naren wants to say something. Let
Yes,
him
Dr.
say, then
Naren?
I'll talk.
Yes.
Yes, ma'am. So I just wanted to share a small tip. I don't know whether it's already covered or not, but one of the things which normally I usually use is capsular hooks. That in the region where the haptic is, I use capsular hook and then place it and then use the viscoelastic, and everything else is similar. So that what happens, there's always a counter traction to that particular area. It's constantly, pushing the capsule back. So that's one more way where we can handle these cases a little more easier. Thank you.
I have, as
So,
regards your question,
yes.
Chitra, I mean, I have had a situation where a patient who had a PCR and a multifocal intraocular lens, which was not really in place, and the patient was extremely unhappy with the visual outcome. We had to replace it. So basically, we had to exchange the lens. So basically, we did inject already a good vitrectomy had been done during the primary surgery. So injected dispersive viscoelastic under the lens and then tamponaded the PC and then subsequently brought out the lens and then placed a three-piece lens. So obviously doing a good anterior vitrectomy, tamponading the PCR and then subsequently extracting the lens is possible. Occasional cases where yak capsulotomy has been done in a hurry also have sometimes present with a very unhappy multifocal intraocular lens patient. This can again be dealt with, though it's not, it's best avoided. And sometimes if it's a very small rexis, what I find is what is adherent on the optics of the lens is very strong. And you can make a small nick over there, something like a capsular rexis, if we're able to create a opening, then beyond the edge of the rexis, the adherence of the capsule to the optics is a little less. And once you have created that small neck, then you can go in with the high molecular weight viscoelastic and then create a plane of dissection and get this lens out. So these are just various ways I'm sure all of us try depending on the situation.
Thank you very much